everybody. We're back again for episode 20 of the 120 Pod, which is now also being called, I've renamed it, as some of you know, and we're calling it Laughter Through Tears because basically that's a lot of our lives. All of us sepsis survivors, all of us people living with chronic conditions and disabilities, our life seems to revolve around laughter through tears. So welcome to Laughter Through Tears, the 120 podcast, and I'm so happy to see all of you here. I have a great guest today. She is an RN, and as many of us have discussed amongst each other, nurses have saved us all in various situations when we're in the hospital. So I'm always excited to talk to RNs, and I'm excited that Tammy is here. I have with me today Tammy Johnson. She is an RN, and she is also Associate Vice President of National Clinical Strategy and Customer Relations at Magnolia Medical Technologies. They are located on the West Coast in Seattle. She is a healthcare executive with over 30 years in nursing, 14 as a nurse leader, whose focus has been on raising standards of care for patients, optimizing outcomes, and decreasing healthcare spending by first and foremost preventing patient harm. Tammy has been through presentations at APIC, AVA. There's a whole list here, the American Hospital Association. Tammy has been around to speak at all of these events, organizations. She really has her finger on the pulse of healthcare when it comes to patient safety. And so with all of these other organizations, in addition to, she had an invitation to address the Presidential Advisory Council Combating Antibiotic-Resistant Bacteria in Washington, D.C. And how many of us with chronic illness know about AMR and antibiotic-resistant bacteria? Anyway, Tammy has championed awareness. She is amazing. She has championed awareness of evidence-based, metric-driven improvement processes and programs that result in sustainable positive outcomes for patients. She's always putting patients first. And Tammy holds degrees in nursing, business, and healthcare management. Tammy, that is an incredible bio, and you are an incredible person, and I am so lucky to have you here today.
Oh, Jackie, thank you so much. And first and foremost, thank you for what you're doing to raise awareness about sepsis so that we can catch it early. It's very, very important work. And I very much appreciate what you're doing every day here. It's a joy to be here. And I would just say I'm over the hill, as we say, and that's why that bio is so long. So, thank you for having me.
Well, thank you for being here. And I just want to also mention real quick to our audience that I do work also with Magnolia Medical Technologies. That's where a lot of you see me on Instagram or on LinkedIn, and I'm doing my Hill days with them. And anyway, we're going to get to all of this very soon. So without further ado, Tammy, let's get right into it here with that first question. If you could tell us about Magnolia Medical and how it all began and what their mission is.
Yeah, absolutely. And it was really Dr. Patton, who was a pathologist in Washington, state of Washington, and who was very, very concerned as a pathologist when he would do really root cause analysis on patient death and ferret through that and decide what was the start of this patient's road down to what culminated in death. And many times he found that a misdiagnosis with a contaminated blood culture was the start of all of it. And that really shook him, right? And he felt like it was low-hanging fruit, like we can fix this problem. This is a diagnostic test that we can get right, give the patient a right diagnosis so that they can get the right treatment, and then we can have quality outcomes for that patient. So that was really the start of it. He wanted to get blood cultures right so the diagnostic test would be right for our patients. Because when we're doing a blood culture, we're trying to see, are there organisms growing in the bloodstream? And many times if there are, that can lead to sepsis. And so we know that route is very, very quick. And so we must know very quickly what are the organisms here that we're trying to fight. So we have to get this right.
Right. And there are a lot of, chronic people with chronic illness watch this podcast and listen to this podcast. And so they understand that, we all get a lot of blood draws for various reasons. But when you're really sick, that's when you're talking about doing a blood culture, that's basically, when the nurse or the doctors come in, pathology comes in or whatnot, and they take the blood sample from your arm, and then they take that away to the lab, and that's what they call doing a blood culture, correct?
Correct. Yes, it's just simply a test to get a sample of blood, to put it in the incubator to see what organisms are going to grow out, and then identify those organisms so that we can then give the correct antibiotics that will kill just those organisms. Because typically, when somebody comes in the emergency room and they're presenting very ill and we're not sure what it is, and they'll present with several symptoms that will say, we need to get a blood culture. And the reason that we get this wrong, unfortunately, is because even though we scrub skin very, very well, right, with chemicals, the right chemicals to kill organisms and the right amount of friction and the right amount of time, we unfortunately can't kill all the organisms in all the layers of your skin. And what we know from many studies that have been done is that down in that deep skin layer, right before the blood vessel, about 20% of your organisms stay very alive, no, despite that very good scrub. And so then when you're going with a needle, obviously that has a hollow bore in it, right? It has a tube and then that goes into the bloodstream so that we can pull blood through that needle into the culture bottle. But by going through all those layers of skin where we couldn't kill all the organisms and having that bore, we can pick organisms up that were on the skin, and then they get in the blood culture bottle and we grow those out, and we think the patient's got a bloodstream infection. And we don't know if they do or not because they're skin organisms, right? So we have to be very, very, very careful, making sure that only what was in the patient's bloodstream gets into the blood culture bottle so that we can have an accurate diagnosis.
Right. Right. Because we all have, I've been told, like, we have bacteria called staph on our skin, right? Like, it just naturally hangs out there.
It loves your skin. It loves us. And it's what we call a commensal organism. It's not going to do any harm on your skin just sitting there, right?
Mhm.
Um, but when it gets into your bloodstream, it will kill you. So we have to make sure we have an accurate test saying this was really what was representative of what was in the bloodstream rather than what was on the skin. So we get the diagnosis right, so we can get the antibiotic therapy right, so we can get those quality outcomes for our patient.
Right. And now I've had some scientists here on the show, and physicians, and like I said, RNs. What Deb Campbell was on a few weeks ago, and the thing I always like to ask, you guys always seem to have a reason. Like, I think that people don't understand how much professionals in healthcare, like yourself, or like the doctors who began Magnolia Medical, have vested in wanting to help other people, like that's the reason. And so I always like to ask people, what was your why, about why you went into healthcare, and also, like, for the scientists at Magnolia Medical. I mean, I was lucky to come there and speak last year, and everybody there was so wonderful to me and thanked me, and because they really wanted to hear the patient voice, and that tells me a lot, that they think that our voices matter and they count.
And I think that's 100% accurate. Your voices do matter, and every patient counts, right? And we
Mhm.
want optimal outcomes for every single patient. And I don't consider it a vocation or a job. I consider it truly a calling. Like you're made to do this. And with that being said, I loved being in bedside nursing. But after a personal tragedy, it hit too close to home. And so I moved over to the industry side of nursing where we're coming up with new technologies that drive quality care. And it really advances what we're able to do for patients. And so being in that, I had worked in that for years, and I really thought, okay, my clock is ticking. I need to retire. And
Oh, no.
yeah, I did.
Oh, no.
And then the company came to me and showed me some very compelling data. It was nothing peer reviewed and published. There was no p values on it, what we looked for in science, but it was very compelling data on what happens to patients when we get this blood culture wrong. And I had just lost a dear friend and neighbor from vancomycin resistance. So, vancomycin is a very strong antibiotic, and he had developed resistance to it. And the reason he had developed resistance to it was because he was also a renal patient. So, he had to go in for dialysis, right? Where we actually
Right.
flush the chemicals out like the kidneys would normally do. We do that operation for them externally in the dialysis center. And many of those patients do carry MRSA on their skin. So then when he would get a fever, they would take a blood culture, and often they picked up MRSA from his skin. It wasn't in his bloodstream, but they picked it up with the blood culture because it wasn't done correctly for all evidence-based practices. They picked up the MRSA and then assumed he had a MRSA bloodstream infection. And so he would get 10 days of vancomycin, whether he needed it or not. They wouldn't take the chance. And so that led to his vancomycin resistance and a very untimely death. And when this company came to me, I was like, this is a huge clinical need, and now we have a total solution, right? This was the missing piece for us because we knew how to scrub the skin and to scrub the bottle tops. We knew how to get all this right to get the blood culture right, but nobody was doing anything accounting for those residual skin organisms that we can't clean away. They stay there no matter what, until Dr. Patton came along and he invented this diversion device. And so that takes that first little bit of blood, sequesters it away, and then opens up a new pathway so that only what's in the bloodstream gets into the blood culture bottles. No,
Yeah,
that's our
that's what
story.
the first time I heard about it, I thought of it in terms of like as a patient, if you have to give a clean urine sample, and you never, ever, ever include the first part of the stream because it will include bacteria and other organisms from your body. So when I saw the device, I went, oh, well, that's kind of doing that, but with the blood. It's siphoning off the first portion collected, and that gets sealed away and thrown away, and then they culture the real part of the sample, so to speak, like what comes
Exactly.
after that first part.
Yeah, exactly. Well, it is the almost the exact same parallel because we get skin cells, right, with that first part of a void. So you
Yeah.
don't want to collect that first part of a void because skin cells will come through, and you don't want that. You want to know just what was in the bladder. Just like with the blood culture, I want to know what was in the bloodstream, not on the patient's skin. So very, very similar. You're 100% accurate in that.
Yeah, exactly. And it is a real problem. I mean, I'm so sorry about your neighbor. I didn't realize until I'd been doing this work for a while. I was talking to my cousin, and it was when you mentioned the vancomycin. She was given vancomycin for something, but anyway, it was a prolonged exposure to the antibiotic, and it wasn't necessary for what she had. And she developed E. coli. And luckily she survived. She's about my age, but she developed like a form of like IBS. She's always had like sort of IBS symptoms after that E. coli infection because that was horrific. And, I mean, these antibiotics, don't get us wrong, anyone out there listening, we're not anti-antibiotic. We need antibiotics. We need them, and we need them to be, so refined. And because, for example, Tammy, don't you take or doctors will recommend like different antibiotics for a dental infection versus a GI infection, correct?
Exactly. So when, unfortunately for the patient, right, that got the misdiagnosis,
Yes.
we if we suspect that you're going to go into sepsis or starting to go into sepsis, we will slam you with very broad spectrum, what we call shotgun approach antibiotics, right? So that we don't know what organism we're fighting.
Yes.
We want to kill everything, right? And that's totally appropriate. But as soon as possible, we need to know exactly what antibiotic you need because of the bug that we're fighting within your body. And that's called a targeted approach. And the faster that we can get that information and give you targeted antibiotics versus broad spectrum, the better chance we have of you having quality outcomes. So we don't want you staying on that, just blanket broad spectrum group of antibiotics. So when we get this test wrong, that patient's therapy on those are delayed at least 2.5 days, right? Which leads to all these crazy problems that you're describing. We know from an article I just read that we are facing resistance because of the overuse of the antibiotics. And again, we're not anti-antibiotic at all. If
No.
you need antibiotics, they will absolutely save your life, right?
Yeah.
But if you don't need them, they only increase what we call morbidity and mortality. So they will do nothing good for you. And what happens with them is they disrupt the balance of gut bugs that you have. And then that causes a dysregulation of your immune system, actually. And that is not something we ever want to cause in patients. We can also cause acute kidney injury, putting the kidneys at risk. And then, of course, the patient's in the hospital a few days that they don't need to be there. And the problem with that is there's other really bad bugs in the hospital, right? And they can acquire those just by being in the hospital. 1 in 31 of our patients in a hospital has at least one hospital acquired infection, right? So we don't want anybody in the hospital unless they have to be there. And so it's a cumulative effect, right? This misdiagnosis because we got a contaminated blood culture. Yeah.
Exactly, right. The sepsis protocol is the sepsis protocol. If you go to the ER and it looks suspicious for sepsis, you're going to get those antibiotics. But then they're
Yeah.
going to take blood samples, and then that goes off to the lab, and those results can take 2 days, 3 days, sometimes up to a week for the culture to see if it grows a germ or grows, a bacteria in there. In the meantime, you're getting your antibiotics, and that's what Tammy was referring to was see what the blood culture says, and what Magnolia aims for, and other companies and the hospitals nationwide are aiming for, is to get the blood culture correct. So it's the correct organism, and is it something that's causing sepsis, or is sepsis not present? And then at that time, they'd have to reevaluate how they're treating the patient. And then you don't overuse the antibiotics that you're using if they're not necessary. Is
And
that like,
that's exactly right. And that last point is really key into what drives us as a company as well, because we're facing global antimicrobial resistance crisis. So we have used so many antibiotics, right? That now these organisms have developed massive amounts of resistance to many antibiotics. And so what we know is that the Lancet, which is a British medical journal, they did a systematic review. They looked at everything, right? That was out there, the data for them available. And they said, what we know is that we lose about 5 million patients every year globally because they have a resistant organism infection and we can't fix them. And so that was in 2022. They put that article out, and then they just put another article out similar to that in 2024, but updating it and said what we know now is that from 2025, last year, to 2050, a 25-year span, globally will lose 169 million patients because of antimicrobial resistant organism infection, the association with that infection. And I think it's a staggering number to say, but it's kind of like, well, how many people is that? And so I looked it up, and it's very, very close to all the amount of people that would live in England, Ireland, France, Wales, Scotland, and Spain. That's a staggering amount of death, right?
yeah,
And again, still in the United States, about 30% of the antibiotics we prescribe are unnecessary. And so we don't have great antimicrobial stewardship. We don't steward that antibiotic utilization very well. We need to do much better. And how we do better is we get the diagnosis right. Because if it all starts with having the right diagnosis, right? And then we can give the right therapy. So that to your point, that resistance portion is really, really important, that we all are aware of that, and we do everything that we can to make sure that we very judiciously use antibiotics and not unnecessarily.
right.
No.
Right, because as I've explained also to the lawmakers on the Hill, when you do have sepsis, they will continue using these antibiotics. And I was on them a total of, I mean, all the while I was in the hospital, which was like 2 weeks, on IV antibiotic and then oral antibiotics. I was on vancomycin, levofloxacin, and metronidazole. I think the metro is for the gut, which was when I had a major gut infection. So
Yeah.
anyway, yeah, so I was on these a total of up to about a month and a half. I went off the antibiotics mid-July. I went septic May 22nd. So that's a long period of time. And they did blood cultures on me, and they did identify E. coli. So they knew what they were treating, and that we continued my treatment. But if it were another case and someone doesn't have sepsis and they don't have an infection, they're going to continue those antibiotics for that long. And that's where we get into trouble.
Yeah, it's an average about another 2.5 days. They're on those broad spectrums till that next set of cultures comes back
Right.
and determines was that a contamination we caught from the skin, or was that a true infection? And to your point, thank God we had the antibiotics available to
Yes.
make you better, right? And that's the whole thing with resistance is if we have a patient who gets a resistant organism and develops sepsis from that, their chance of not living is twice that. And so we really, again, have to do everything judiciously in our utilization of antibiotics. Again, they'll save your life if you need them, but if you don't need them, they will only cause you harm. So really
Yeah, that
important.
is the important thing. Some patients, like with cystic fibrosis, watch this
Mm,
podcast, and a lot of them are on antibiotics. Cystic fibrosis patients alone are on antibiotics, sometimes constantly.
mm,
And we want those to work. Sepsis survivors are more likely to develop sepsis again. I want to
mm.
make sure that the antibiotic works the next time I need it to work, if that scenario develops again. So I just wanted to make sure that our listeners understand too how crucial this topic is, because it's really something, as far as patient safety goes. And speaking of that, so what is your role at Magnolia Medical? Like, what do you do there now, that you're not in the hospital nursing, so now you're doing this?
Yeah, in the beginning, it was really just, have the trial the new device within hospitals. And then they got amazing results and amazing change in outcomes for patients. And so then they would take that information and the data that they collected from that and then get that published, right? And in those quality journal publications where, we look for p-values saying, what if my hospital wants to do this? Well, I get the same results if I do the same thing. That's basically how I understand a p-value. But that's very important work because we always want to give evidence-based medicine and therapy to patients. And so it has to have and develop that evidence base. So that was my job in the beginning. And then making that data and those articles available to healthcare societies. And the CDC and AHRQ and Infectious Disease Society of America and ENA and INS, all of these healthcare societies have now developed out of that data their guidelines for how we should collect a blood culture. And so it really was my job to take that, make sure the clinical trials were in place. There was success from them. There was paramount success from them. That was published, right? And then that body of evidence was absolutely communicated because unfortunately for us, it still takes us about 17 years to get about 14% of new evidence-based practices to the bedside. And in that lag time, so many patients could have benefited from that, right?
Yeah.
So as a nurse, you're always challenged to make sure you're keeping up on new evidence-based practices and bringing that to your patient population at the bedside. But there's still this tremendous lag in that. And that's really unacceptable, right? So really pushing hard to make sure the information, the data, the peer-reviewed data was out there so that we could make informed decisions about really what is this new evidence-based practice that should be included in this blood culture collection bundle, because we have to do all of it right, right? No,
Right. 17 years, Tam. Wow.
typically
Wow.
to get 14% of
Oh,
new evidence evidence-based practices. Yeah. So it's a struggle.
Yeah, I know the wheels turn slowly, but yeah,
Yes.
that's so you're in charge of like analyzing this, getting feedback, seeing what's happening in the hospitals using this protocol.
Right. And then just really making sure that all evidence-based practices are used, right?
Right.
So there's very few things in medicine that something is, a golden bullet. We absolutely have to understand that most things are a bundle that we do. There's multiple sets of practices around what we do, and all of them have to be followed all of the time. So we can't pick and choose, because what if that was your child in the bed? What are you going to omit in that bundle of practices, right? We need to do it all. And for if we don't know something, right, then that's not on us. But when the knowledge is there and the evidence is there and the great data is there and it's scientifically proven,
Yes.
then I believe it's unconscionable to not do the right thing for our patients. And patients need to know what's available to them, right? That's the Unfortunately, we have to be our own advocates in healthcare, but it is a reality. As you know, you've walked down this road, you have to be your own advocate.
I stress that all the time. Anybody who's been to my sepsis talks here in my I'm like in the classroom again. I used to be a school teacher, and I tell my story, and we talk about sepsis. We talk about all these things, the antimicrobial resistance, and the thing that we always end on is a very interactive discussion with everybody raising their hands and commenting about how important patient self-advocacy is. We owe it to ourselves to know like the conditions that we have. We owe it to ourselves to learn about this antimicrobial resistance. I interviewed a patient with COPD recently, and he said, you got to make it your business. If you have COPD, he's speaking specifically to those patients, you got to make it your business to become an expert on your disease and know all you can. So I think that collaboration between the medical providers and the patients is very important. And speaking of other medical providers too, so Deb Campbell, who I had on the show a couple of weeks ago, she is with the Kentucky Hospital Association. And she told me, I mean, they've had astounding success with paying attention, making this a priority issue in all of the Kentucky hospitals in the state. And they have brought their hospitals, some of them down to the rate of zero, like zero, no blood culture contamination whatsoever, which is incredible. What do you, what do you know about KHA and Deb's hospital's practices and how that might translate to other hospitals? My podcast winds up on the American Hospital Association's website in the nursing section. So anyone listening from that viewpoint, what would you say about KHA and what other hospitals could do to mimic that?
Yeah. And I would just say, if you know Deb Campbell, to know her is to love her. I have never known anybody who fought so hard and continues to fight so hard for patient quality outcomes. She is a force, and she has so impressed me time and time and time again with her patient centricity. Everything is about the patient outcomes, right? And she will fight long and hard to make sure that change in a very positive way is made and continues to be made. Um, the fact that some of those hospitals are zero is phenomenal, because in our eyes, zero is the only acceptable number for harm, right? So we have a rate that we want to achieve, but really zero is what it should be. We should never have a misdiagnosis. And that is fantastic, because then we know, because it's like, I think it was British Medical Journal again had an article on patient safety. And what they said is that still in the United States, every year, 795,000 Americans are either end of life or permanent disability because we misdiagnose them. We miss what was wrong with them, right? And it's just something that shouldn't be happening, right? We're way better than that. And I know we can do, but back to Deb, she gets this, she feels it in every bone and morsel of her body to just really push and push and push and make it better. And when you can accomplish something like that for a state, so not only does that help the patients of Kentucky, because then you know antibiotic resistance is going to go down when antibiotic utilization goes down, right? We know that goes hand in hand. And so then population health gets better. It's just a better, healthier place. So there's many, many, many outcomes from doing quality health care, and that's really her focus and her aim. And other states have done that too. I know Indiana, they've taken a huge look at this and looked at how they're going to measure and report blood culture contamination, and they've done a ton of work on that. And I would say that the CDC has done a phenomenal job as well. Dr. Nancy Cornish and Jake Bunn have led these efforts just in an amazing way. They just had an article in Journal of Applied Laboratory Medicine that really say we need a national measure regarding blood culture contamination because we know of all this patient harm that comes out of it when we get this wrong. And so hopefully we move in that direction, right? Where we really understand how bad this is for patients, and then how we can do this right, and then really adopt those practices as a true standard of care throughout the United States and hopefully the world, right? Because we're not the only ones that suffer with this.
Right, right. And you're right about Indiana. So it's Indiana has also been paying attention to this issue. Kentucky. Are we missing anybody are there any other states who are looking at this more closely?
I think many states are looking at this very closely because there's been so much information about it, right? And CDC put out, here's a strategy to deal with this, right? And then HRQ did some wonderful work on it, and we've had many organizations as well as Microbiology Association and mentioned ENA and Infusion Nurse Society and CLSI did a lot of work on it. So it's been amazing in APIC and SHEA, Society of Healthcare Epidemiology. So many, many groups within healthcare have looked and said, we need to do better and push new standards for this so we get this right for patients. I would say the downside is that we haven't adopted it as a standard of care throughout this bundle, this evidence-based bundle, throughout all the hospitals in America yet. We're on our way.
Right.
But
And
we need
that's why the work we're doing on the Hill is to make that happen because
yeah.
it needs to happen. It needed to happen yesterday, but we need it to happen. I'm also going to include links in the description box below, like to the Kentucky Hospital Association, Indiana, of course, Magnolia Medicals. And I can't flash it on the screen live while we're talking, but I am going to put on insert later a picture of the SteriPath device because I thought that might also help people, and they're looking at it and they're looking at the cylinder and just to kind of understand what the device looks like. And as you explained, that's a blood culture collection device, and I've had a lot of blood draws before, so they put the needle in, right? And they use the device is attached as well.
Correct. What it is, it just provides what we call a vein to bottle closed system because we never want to open anything up because there are organisms everywhere, right? So a vein to bottle closed system is ideal. And so that's what this is. In the beginning with Dr. Patton with his studies, he was just, taking a waste tube and diverting little bits of blood and seeing how much actually do we need to take off that first portion of blood in order to capture those skin organisms that may have been in the needle, right? And so what that did is give him an idea of how much blood we needed to collect. It's in around a milliliter of blood, that first milliliter, which is a very small amount. And then that is sequestered. So it goes into a little area and it's locked away. And then a new pathway is opened up so that, again, you don't get skin organisms in the blood culture bottle. It's a new pathway, sterile pathway from the patient's vein to the collection bottle. And then that way we can be sure that, yes, if I grow this out, I can bet my bottom dollar, right, that that really was in the patient's bloodstream. And when I'm treating them with these very powerful antibiotics, right, and when I'm seeing, oh yeah, it was a skin organism, but it actually grew in their bloodstream. And we know then what exactly antibiotic they need and what we are attacking from a healthcare perspective in order that that patient can have the best outcomes possible.
Right. And like the audience will be able to see the picture of the device. I mean, it's small, it's very simplistic in a way.
It is.
So
Yeah.
it's, yeah,
Everybody says, why didn't I think of that? Right?
yeah, yeah,
And it's,
exactly.
and
I
if
mean,
you do
and
think
it's,
it really,
and simple is the best way. I mean, if I can understand it, and I'm not a nurse or a doc, anybody, it's easy to figure out how it works. And now let's see, the 10, I had a question in here, and it's been a while with our technical issues and everything. We had to kind of keep rescheduling our podcast. Can you refresh me on the 10 Healthcare Society guidelines? Like, elaborate on that a little bit, like what that is and what that has to do with all this.
yeah, those societies really give us guidance, especially HRQ. That's a federal agency that looks at what our evidence-based practice is and then puts them out there for us, right? And then the other societies that I mentioned, they are specialists in that field, like Society of Healthcare Epidemiology, right? The Society for Microbiology and Infectious Disease Society of America. So, with all of the new data that came out, and all key thought leaders looking at this and saying, we can do better. We can make this better for patients. We can cause a lot less kidney injury, right? We can cause a lot less Clostridioides difficile infection. We can, get patients out of the hospital if they don't need to be there and keep them and treat them appropriately if they do need to be there. Diagnostic accuracy is key. And so they all came up with their version of their guidelines, strategies, suggestions of how this collection practice should be done. And so you'll see from APIC to everybody else, they have done this in a very scientific manner so that they've gathered the data that was very quality peer-reviewed data, inclusive of CLSI, which is kind of the Bible for us on blood culture collection, and then brought that out and sent that to their membership. So when you're a nurse or a physician, you're not only a nurse or a physician, but you have a specialty, right? And in that specialty, you usually have a society that you belong to that keeps giving you more evidence-based practices and what's new and how do we improve patients' lives. So that's really why those guidelines are so important, or if they wrote a strategy or whatever it is that they put out there, really important to pay attention to what is new, what is evidence-based. And as I mentioned, I had to take an oath. Yes, it is part of my oath to bring new evidence-based practices to the patient bedside. Because we can have all these things, right? We can have great p-values and peer-reviewed literature, but until we bring it to the patient's bedside, it's useless. I mean, that's the whole point of all of it, is to getting it into the practice of hospitals in the United States so that we're doing it right so patients can benefit.
100%, 100%, Tammy.
So,
And that's the thing. The more and more that I talk to all of you on on these episodes, I'm really, if I were to go in the hospital tomorrow, I'm confident that everybody there is trying to hold my very precious life in their hands and take it. I mean, it already happened when I went septic, of course, the way that everyone, it was sort of a team effort from the ER to the trauma center I was flown to those surgeons and all the aftercare. And I just, listening to you talk about all the societies and how much there's like a system. I don't know if checks and balances is the right phrase, but it's sort of like there's a discovery made. Somebody says, hey, I got this great thing, but it doesn't just land in the hospital right away. We don't just throw it out there and hope it sticks to the wall.
yeah.
But all of these very esteemed professionals are looking over each other's shoulders and double checking, and this society has to weigh in, and this society has to weigh in, the Society of Endocrinology, the Society of American Pathologists, the society. I mean, these societies are so vital and necessary, and they are what keeps the medicine we receive and the treatments we receive to be the most accurate they can be in that way, in the same way that you're driving and promoting for less rate of zero blood culture contamination. But it really gives me like confidence as a patient with chronic illnesses that no matter what hospital I wind up in or, who's caring for me, I know there are professionals in there who are trying to do their very best. And thank you, by the way, all of you.
100%. And thank you for trusting us, right, in your hour of your greatest need. And I would say I've had the same experience when I had to go in the emergency room, right? It was like, oh, help me God. And they were amazing. And you're so grateful for the care that you receive. And it's really a huge privilege for us to be in the United States. You'll hear a lot of dialogue about, well, we spend so much money and yet our outcomes, but understand we take the sickest people in the world into these institutions, right? We have the hardest patients. And it is really proven over and over and over again. Where would you rather be for healthcare outcomes? I wouldn't rather be anywhere else because even though we're not where we want to be, even though we still have 795,000 people either losing their life or in a permanent disability because we've misdiagnosed them, right? We always have that pressure to do better, to do better, to do better. And that's in large part with exactly what you're doing here. It's information shared about how we can do better and why we need to be better, because we're never satisfied until we have zero patient harm.
And that's the whole point. That's the whole point of this episode is blood culture contamination rates are a problem and they need to come down. And that really, I think, speaks to what Magnolia's, where is Magnolia heading in the future? Like, what are the goals? Obviously, I'm going to urge anyone listening or watching to go to the Magnolia website because I know you'll see their goal right there on the on the homepage.
Yeah. I think the most important for me, and I know the ultimate goal for the company, is that all patients everywhere would have an accurate diagnosis with a blood culture, right? We want to make sure that it's not just a standard of care in the literature. We want to make sure that every patient receives the best possible outcomes because they didn't get a misdiagnosis. And that's really our goal. It's what Dr. Patton started with, right? And what I hope we always will have as our end goal is that the faster that we can do this, the more lives will be saved, the more kidneys will be spared, the more antibiotics will not be used unnecessarily, right? The slower rates of resistance, all of these amazing outcomes just because we're starting to get this right. So I think that's, the shared goal of everybody is to do better every day and make sure that we're doing all evidence-based practices all the time for every patient.
And we'll have antibiotics that work for the
Exactly.
patients who need them, for the sepsis patients who need that vancomycin to work. It will continue to work.
Yeah.
And
Very, very critically important.
Yeah. I feel like I tiptoe behind, I don't know what the actual saying is, something about the shoulders of giants or something. I am lucky to be surrounded by people like yourself and other scientists and everything, because in the last like 2 to 3 years, I have learned so much. I was at a conference last week and learned so much about biomarkers, something I never, before my sepsis crisis, and I got involved in all that, didn't know what it was all about. But you guys are a very impressive group of people. I got to say that. It's just.
We have so much to be thankful for. It's not that we're impressive, it's that knowledge is shared, right? And these true scientists do this true research and they share their results and we can all benefit from that. And we ask hard questions And I think that's the point of science. You never stop asking questions. Keep asking why and keep digging deeper and deeper and deeper and deeper, and you will come up with a solution. And it's very true for healthcare too, right? We don't just let things keep going bad. We have to dig in and see why and how we never repeat the error. And part of this was just this passion of Dr. Patton to say, this is low hanging fruit. We can fix this. We can get this right for patients. We have a bit of a solution, but we're still having all these bad rates because we don't have the total solution. And now we have a total solution. We know what that bundle is, that evidence-based bundle is, and we know we need to use it on every patient every time for their outcomes and their quality of life. So, yeah. So
Absolutely.
we
Again,
so appreciate what you
100%.
do.
Yeah.
Yeah.
You and I had spoken a little bit over the phone, and I was telling you it was last week. It was Sepsis Survivor Week, and so many of us advocates felt like we were banging our heads into the wall. Advocacy, is hard work. When you're a patient with disabilities, it feels like it's really hard work, but it's rewarding work. But oftentimes the reward is intangible, like we don't see it. And I was feeling very down in the dumpster last week, and you read something to me that, yeah, I'm going to cry again, but it bears repeating. I'd like my audience to hear it, because it could apply to a lot of things, just it's a really good passage. So would you please send us off with that before we sign off today?
I would be happy to, but first I want to say thank you again, Jackie, for having me here. Most amazing work that you are accomplishing in that sepsis awareness is the key to combating this disease, right? And to getting people through it much faster and much better outcomes. So we can't thank you enough for what you're doing as a sepsis survivor and even on the bad days pushing through. So there's a hero of mine in healthcare, and his name is Dr. Don Berwick, and he was the founder of Institute of Healthcare Improvement. And he was another one of these wonderful people that just kept pushing and pushing and pushing for bettering outcomes for patients. And there's a beautiful quote from him, and it applies to you. And I don't know if you printed it out and put it in a picture frame on your desk, but if you didn't, I want you to.
It's
And I want you to
printed.
be
It's not in the
good.
frame yet, but it's printed here on my desk.
Excellent, because I love it, because we all get despairing of like, oh, I feel like I've stepped 1 foot forward and now I've gone 3 back, right? And on those days, just please read this to yourself. And Dr. Berwick says, the names of the patients whose lives you save can never be known, but your contribution will be what did not happen to them. And though they are unknown, you will know that mothers and fathers are at graduations and weddings they would have missed, and that grandchildren will know grandparents they might never have known. And holidays will be taken, and work completed, and books read, and symphonies heard, and gardens tended, that without your wonderful work would never have been. So I thank you from the bottom of my heart. And if you're having a bad day, you read that or call me, okay?
I love that passage. As you read it, I picture less empty chairs at the table, and those chairs still filled with people's loved ones. And the graduation thing, that and weddings, and yeah, it's a good passage, Tammy. Thank you for sharing that with us. And I want to thank all of you, my audience, for being here again with me today and with my guests. And, we just are so happy that you tuned in. I want to just make one last quick reminder that the Laughter Through Tears, the 120 pod, is not intended to be medical advice. Remember, if you have a medical emergency, if you're sick or something, call your doctor, call 911, or head straight to the emergency room. And this is just for information purposes only. And thank you all for being here. And Tammy, thank you again.
Thank you.